Hi, everyone. I am really excited to speak to a colleague and friend of mine who I met several years ago through the Integrative Medicine Fellowship that she and I did together at the University of Arizona Integrative Medicine Center that was started by Dr. Andrew Weil. Please meet my colleague, Dr. Tricia Thompson, who practices emergency medicine on the Eastern Shore of Maryland. And she also has her own integrative health practice called Maryland Integrative Health. And she and I have had some very interesting conversations over the last week or so about COVID-19, all of the current topics that we're hearing about in the news, and felt that it was really important to talk about some of the facts and some of the things that both Tricia is seeing on the front lines, but also that we know so far. And then kind of really tying that into what does this mean in terms of our ability to control for some of our risk factors and some of the determinants of the morbidity and mortality of COVID-19 that we're seeing. So welcome, Tricia.
Thank you so much for having me. I'm really excited to be here. And I think that, you being in New York City and me being in a place that's on a different curve, I think makes a difference because we've had some more space and time to look at this that's New York kind of didn't have because it came in such a flood to you.
Right, absolutely. And I think, I've been hearing a lot that from, the doctors on the front lines that that it's been so helpful for people who have gone through that wave and through that peak in the curve earlier to share the information, share what they're seeing, and really help out the colleagues that are kind of now starting to catch up. And maybe we can just kind of dive right into that because COVID-19, or it's really the SARS-CoV-2 virus that's causing the COVID-19 disease, is unlike anything really that's been seen before. And being on the front lines and seeing patients with this, I know that you shared some really interesting pearls about it, and I've certainly read a lot about ER doctors, critical care doctors sharing information about how this is so atypical, how different things from ventilation settings to when do you start ventilation to what discharge instructions do you give to people because the presentation is so atypical. So I'd love to dive into that a little bit. And, I know that we all know that, symptoms to watch for might start as a typical upper respiratory infection and may involve fever, shortness of breath, cough, but it can involve a number of other presentations and can have this very unusual course. So maybe you can share with us a little bit about what you and your colleagues have observed so far and how and why this is so different and in a way scary.
So thanks for asking that because I think that people, have heard that your first symptoms are kind of body aches and fever and headache, and that's true. But I think that most people are sick a couple of days before they even start having that. And I haven't heard, like with the flu, lots of people have that, their eyes ache. They can feel it coming. I haven't heard that so much with COVID-19. So by the time that they're sick, they're like, oh, I'm sick. And they're in bed. They have fever, they have body aches, they feel miserable. And that's about day 3, day 4, day 5 of the illness typically, where they're very fatigued, they just want to sleep. They get some relief usually after day 5 or 6, where the fevers in the daytime at least start to calm down, but they still tend to be very bad at night. And then day 7 and 8 is kind of the turnaround point. Either people start to get better, the cough starts to get a little easier, the fevers are less, they are not as tired, they can do a little more. But that seems to be kind of the magic point when they either come to see me because they think they're getting worse, or we have to reassure them that they're going to be okay. And the way we tell that when they come to the emergency department is a bunch of things. One, how they look, and we can really tell by looking at somebody whether they're on that downward spiral or coming up from the curve of the illness itself. We also check their oxygen level, and that's really, really important. What we found is that the sicker patients have a lower oxygen level, maybe not at rest, but we literally make them walk laps in the emergency department with the mask on, and then we check their pulse ox. And if their pulse ox drops, that's an indication that even if their x-ray looks okay, if we're very suspicious that that's a person who has the potential to get more ill and require more support, including the hospitalization and maybe going on oxygen at some point.
Absolutely. And one thing you shared with me that I thought was really interesting and very unusual, when I think about patients, when I was doing inpatient care during residency training, typically when you encounter patients whose oxygen saturation is dropping, they typically tend to really be in distress, and they have this tripod position, and they're kind of really, air hungry and trying to get as much air in as possible. And interestingly and kind of frighteningly, you shared with me that that's not necessarily the case with people with COVID-19. There's almost a kind of adaptation, or the body is sure the respiratory rate is elevated, and we can talk a little bit about what's normal and what's elevated, but they don't necessarily subjectively feel or maybe even look in distress other than the high respiration rate.
Yeah, it's a very different picture. And we see patients with congestive heart failure and COPD and asthma all the time in the emergency department who are very short of breath, or sepsis with pneumonia. And they are working, they're sweating, they look bad, they're really struggling for air. And what I found is a lot of these COVID patients are laid back. They're on their phones. I mean, they're breathing 40 times a minute, which is significantly faster than normal. Normal is kind of 12 to 16. So their breath rate is faster, but they're not huffing and puffing. They're not really in distress. If they start talking a lot, they say a lot of words in a row, they'll kind of have to take an extra breath, but they're not as in distress as you would think for the number, which is the pulse ox. So perfect pulse ox is 100%. We think of anything above kind of 90, 92 as okay for most people without underlying disease. And these people come in at 75 or 80, and they look pretty comfortable. It's different, medically speaking. They look different than our other respiratory distress patients with a stat of 80.
And the other thing that you shared as well is that they may not necessarily, because again, when we think of people with heart failure, with sepsis, struggling to breathe, they typically have quite an elevated heart rate, unless they're on beta blockers, which are medications that slow down the heart rate. But you're finding that in these patients, they may not necessarily have such an abnormally elevated heart rate. It might be a little bit elevated, but not to the point where that would cause alarm right away, or that they may even necessarily notice.
Correct. And usually the heart rates I'm seeing in afebrile patients, so patients without a fever at the time that we're seeing them, it's kind of high 90s. So a normal heart rate is 60 to 100. Most people that are healthy run 60s to 70s all the time.
Right.
And their heart rate goes up when they exercise or have activity. But these patients, their heart rate's about a 90, 100. It's not 130, 150, unless they have a fever. And then when there's a fever, their heart rate significantly does go up. And the fevers we're seeing are high, 103, 104. They're high fevers.
And do you find, and again, this is just very much, I'm asking anecdotally, do you find that people, and do they ever report to you, I normally run a high fever if I get the flu or another type of infection, versus, I normally don't run a high fever, but this is atypical for me. Do you know just anecdotally if that's a correlation, how you've reacted to prior infection, if that in any way, if we know if that in any way predicts how we might respond to COVID-19?
Yeah, I don't know specifically about that, but my sense is that the patients that have a fever, they're like, this is a fever. They know they have a fever, and they're like, I've never had anything like this before. So they definitely notice that this is a different type of fever, even if they've had fevers in the past.
Sure. Got it. Okay. And now one thing, and again, just, to remind anybody watching, this is informational only, it's not medical advice, but one thing that we touched on in our conversations, and that I've certainly talked to my other physician colleagues about too, is that given this atypical presentation, are there certain instances where you might counsel a patient to purchase a pulse oximeter? And again, this doesn't necessarily mean that everybody out there needs to go out and get a pulse ox, but in certain situations where one can't necessarily quite tell, is my breathing more labored, or am I breathing faster than normal? Do you have certain patients in the course of their illness where you may tell them, okay, you're healthy enough, you're stable enough to leave the emergency department, but it may be really helpful for you to continue monitoring yourself at home, because we've seen this seemingly fast decline, and people go from not requiring any supplemental oxygen to needing to be ventilated.
Yeah, so I think there definitely is a role for that. I've heard that the pulse ox that used to be $10 on Amazon is now $50.
Of course,
So
right.
people are clearly, there's clearly a demand, but they're fairly inexpensive, and they work well, and they're very accurate. So the pulse ox is one thing. So if your pulse ox, you check it, and we send a lot of people home from the emergency department with this illness, and we tell them, you're early, you're healthy, you're probably gonna do fine. And 95% of the people, we don't ever see them again. But we also tell them, if when you get up and you walk just to your bathroom and back, and you're huffing and puffing, or you just feel like you can't, takes you a long time to catch your breath, that's when it's time to come back and see us. So while a pulse ox is helpful, clinically, they can start to tell there's a difference. And we tell them, yeah, I'd rather send you home twice than for you not to come. So I'm happy to check you again in a few days and see where you are, or have your primary care doctor check you again in a few days to see where you are. Because a lot of people, as we all know, will get better without any intervention. They don't need to come to the hospital. They don't need to be, in the hospital. So the clinical symptoms, I think, are what we're sending most people home with. But a pulse ox probably can't hurt if it's within your budget, and you find that it was 95, and then it was 92, and then you got up and went to the bathroom, and you came back and it was 80. Yeah, that's probably the time to come back and see me again.
Absolutely. And we talked briefly, maybe you can comment about a study to kind of segue a little bit into outcomes and what different hospital systems are seeing. But you shared with me a comparison between patients in the UK and patients in the US that get ventilated, so that require ventilation support, and that the statistics are quite different. It seems that people in the UK overall do better in terms of mortality once ventilated versus people in the US. Can you comment a little bit about that?
Yeah, that's a brand new study. I literally read it the day before yesterday, and it was kind of ooh, this is interesting, and nobody really knows what to do with it yet. So I don't think people have dived deeply into the difference in either the underlying pathology. So is it that those patients had less comorbidities, but waited a long time and came in and needed the vent, but they didn't have other underlying things going on? Or did they put less people on the ventilator in the UK proportionately, because there was some tendency to put people on the ventilator early, at least a few weeks ago. I think we're actually trying to keep people off the ventilator as long as possible, because people, once they're on the ventilator, have not been doing as well. So I think that diving into all of those details will be very interesting, but I don't think we have an answer as to why yet. Why that difference, but it was substantial.
And right now, can you speak to the percentage of people that currently are able to, once intubated, once on the ventilator, that are able to wean off the vent and kind of and improve?
So the numbers are really low. The numbers are probably less than 15%. So and I think that we're improving in that all the time, but this is a constantly moving force. And as I'm online even this morning sharing information with colleagues around the country who are doing different things. We're all getting new ideas, and none of us have treated anything like this in the past. So, and it's not typical what we hear of ARDS, which is this acute respiratory distress syndrome. It's a different pathology, even though it looks the same. So we're still trying to figure out how to manage it. And I think we're getting better as we go along. But that being said, we also talked a lot about the things that seem to make people worse and the things that seem to put people on the ventilator or put them in that position. And, they are the chronic diseases of America. It's high blood pressure, but more importantly, obesity and diabetes. Those are the two biggies. And, the obesity thing, I was a little surprised by, actually. Not because even those patients that we think of that are obese and healthy, they don't have high blood pressure, they don't have prediabetes, they don't have diabetes. They're young, but they happen to be obese or morbidly obese, especially with a BMI of greater than 40. Those people just are really struggling with this disease, and they're getting very, very sick.
Yeah.
So I think that we've really got to keep looking at, and my functional integrative medicine side says, this is such an opportunity for us to really focus on these things that are, that we can prevent, that we can turn around, that we can make better, so that we don't end up in the future.
Absolutely, because these conditions are preventable in large part, and we can really play a significant role in terms of modifying our lifestyle habits, our nutrition. But then it's also a larger public health issue and a societal issue of how hard is it in our current society and with our current lifestyles to actually maintain a normal body mass index, right? I mean, with everything that's available and pricing wise more attractive, but also taste wise maybe more attractive. And then, the stress causing some unhealthy habits and all of that. I just wanted to share some statistics just so that people listening can kind of get a sense of what we're talking about when we talk about the prevalence of these comorbid conditions of people that are coming into the hospital with COVID-19. So there was a study that came out in the Journal of American Medical Association on April 22nd, and we're recording this on April 24th, so a couple of days ago, that looked at 5,700 patients who were admitted to the hospital system, Northwell Health, in New York City and the surrounding counties. And they collected outcomes for 2,634 of these patients. And they looked at the comorbidities or the other underlying conditions that these patients had, that they were admitted to the hospital with COVID-19. And what they found is that almost 57% of these people had high blood pressure. As Tricia mentioned, this is something that that tends to put people at higher risk of doing worse when it comes to COVID-19. And the prevalence in New York, I looked this up just 2 years ago, in 2018, the prevalence in New York City and the surrounding counties of hypertension is 21 to 35%. So we can definitely see that the people coming into the hospital being admitted with COVID-19 are overrepresented. We're looking at 57% of those have hypertension, but in the general population in these areas, 21 to 35% have it. And then diabetes, as you mentioned, about 34% of these people admitted to the hospital with COVID-19 have diabetes. But last year in the New York State, the reported prevalence of diabetes was 11%. So these people are 3 times as represented among the people that are admitted. And then obesity, again, just another mind-blowing thing. Almost 42% of the people admitted with COVID-19 had obesity, whereas the statistics are 28% in 2018 reported by the Department of Health in the state of New York in terms of obesity. So again, these populations are overrepresented in the people that are admitted with COVID-19. So we know that there's some clear lifestyle factors, and I'm sure we'll learn more, and it'll be, I think, so interesting to see what other factors play a role. What else can we modify? Right. What are the non-modifiable factors where those populations we really have to make sure that they don't get it, that we keep them safe? But what are the modifiable where people can start working on those things now?
Right. And I think, we're talking about New York statistics here,
Yes.
but I don't think it's any different anywhere in the country. I can tell you right now, looking at the patients that I'm seeing come in the door, the ones that we're sending home versus the ones that we're keeping, it's the same ratio, the
Pattern.
same population. Yeah.
And there's something in particular that I read. There was an article that came out in the New York Times that also looked at these statistics, and there was a concern raised specifically about younger people with, again, only obesity, no diabetes, no high blood pressure, younger people with obesity having worse outcomes. And again, something that, again, the younger populations often may feel, we're immune, we're fine, it's going to be okay. But we're hearing about these cases, which is quite alarming.
Yeah, it is alarming. And I'm seeing it in real time. We really are seeing patients that, aside from their weight, they wouldn't be in the hospital.
They wouldn't be. Right. Yeah. So definitely a lot of things we can do. And then just in terms of another large study that came out of China and also was published in the Journal of American Medical Association, they looked at the case fatality rate. So the people that die as a result of COVID-19, and they broke them down into people with, again, different comorbidities. And again, we're seeing a similar pattern as with those individuals that are more likely to be hospitalized. So they studied 72,000 case records, of which about 44,000 were confirmed cases. About 44,600 were confirmed cases of COVID-19. Mm-hmm. And of those, the average case fatality rate was 2.3%. But when they looked at people with cardiovascular disease, 10.5%. People with chronic respiratory disease, 6.3%. Diabetes, 6.3%. Cancer, 5.6%. So again, we know that a lot of these chronic conditions that are in a way, and we know that, again, even just talking about cancer, there are many types of different cancers that are associated with lifestyle, body mass index, what we eat, and so on. So of course, it's multifactorial. There are many other factors at play, but there are also lifestyle factors that all of us can control.
Yeah, and I know you and I probably haven't talked about this specifically, but when I think of how to approach somebody from an integrative medicine standpoint, a huge piece of what we're looking at is inflammation. Yes. And all of these diseases that you're mentioning, all are inflammatory processes in the body. And COVID-19, the illness seems to be very pro-inflammatory. We are seeing lab tests that are through the roof. So we look at something called a CRP, which is a C-reactive protein. We usually refer to it as a non-specific inflammatory marker. And sometimes we check it in patients that we think have an indolent infection, like an osteomyelitis, an infection in the bone that's hard to find or hard to see. We check it in patients with, chronic arthritides like rheumatoid arthritis or lupus, to kind of monitor where they're going. And an elevated CRP in my lab currently is greater than 3. And some of these patients with an osteomyelitis or whatever, or even a bad bone infection, you'll get them to 30 or 50. And you're like, whoa, that's a deal. Mm-hmm. My patients with COVID are 300.
Wow.
240. They are all through the roof. So there's a huge inflammation piece to this. Mm-hmm. And I don't know, we will know in a few years, looking back, how does that play in? But what we're seeing is this huge inflammatory response in the body. And I don't know if it's the virus causing it. I don't know if it's the immune system's response. And we can't really tell yet. But that inflammatory piece, if we start in a less inflammatory state, then we have more space to go.
Right.
So that is something from integrative medicine perspective we're always looking at. How do we decrease the inflammation? How do we decrease the inflammation in the gut? How do we decrease the inflammation in the brain? How do we decrease the inflammation in the joints? All of these things that cause people pain. So that's the things that you and I work with patients every day on, that it's striking to me, the lab test results.
Absolutely. I mean, that's an extremely elevated CRP if we're talking 200-300. I mean, that's, yeah.
Yeah. Wow. Some of the highest I've ever seen in my whole career.
Yeah. Yeah, absolutely. I mean, and to kind of tie into that and the lifestyle and reducing inflammation, another statistic that I looked up um, recently was because one way to reduce inflammation in a normal pre-COVID-19 state is looking at our nutrition, right? So increasing the plant foods in our diet, increasing the whole foods, plant-based um, foods that we're consuming, and study after study shows that in this country we are under consuming our fruits and vegetables. I mean, there was a statistic in the state of New York where they looked at county by county what percentage of individuals eat greater than or equal to 5 fruits or vegetables a day. So this is fruits or vegetables. 20 to 33%. So at best, a third of the people consume 5 or more fruits or vegetables. So that
Which is
means
naturally anti-inflammatory. And then we
exactly.
can look at the flip side of that, which are the pro-inflammatory foods. So we think of fried food, fast food, hyper processed food. So everything, I tell my patients, nothing out of a box, a bag, or a window. Like
Yeah.
you have to eat real food. And that's a huge opportunity that changes everything in a very short period of time. So yeah, increasing the fruits and vegetables, but more, I almost want to do more of taking away those things that are so pro-inflammatory. The hyper-processed foods are really a huge piece of that.
Absolutely, absolutely, they are. And sometimes again we don't know, we can't necessarily sense unless, as you said, somebody has rheumatoid arthritis or lupus or inflammatory bowel disease or another condition that may act up as a result of the food that we're eating. And sometimes symptoms might be subtle. And just anecdotally to share, I mean, I know for myself, and I certainly have patients who feel similarly. And again, without any autoimmune condition that's diagnosable, but I know if I consume a great deal of sugar, and I occasionally do, like I do, and I'm not not proud of it, not, but I occasionally do. But I notice that I get joint aches that can last for about a day or so. And whenever I'm eating, and I've done this experiment multiple times where I'll go for weeks with a very clean, healthy diet, and then I'll be like, oh, I just need to have something sweet. And if I do that, I will notice joint aches. And again, this is in someone with no autoimmune disease, nothing diagnosable at this point. So I think it's just important to maybe be in tune, even if one has subtle signs, just to know, hey, this is how this food is making me feel. Let me see if I can change some of this, and if I can mindfully, and of course we all slip up and we all have our thing, but just to kind of think rationally about, okay, how do I incorporate more foods that are serving me well and cut down on this other stuff, and not have it be the staple of my diet, because those joint aches or whatever, those subtle, or fatigue, we eat a lot of sugar or processed or carby foods, may not be uh, um, it doesn't have to be something sweet. It could just be a carb loaded meal. We feel fatigue. We feel kind of drained. We have that spike in blood sugars, and then and our insulin, and then that dip. And so I think it's just important to, as maybe the first step, to be mindful of how are we feeling? How is this making me feel? And what what can I do? Do I work with a health coach? Do I work with a qualified healthcare provider to start making some changes?
Absolutely. Yeah, no, I think that you're exactly right. But I think most people, their diet isn't clean enough to even notice those subtle changes.
Settle.
So until they make a change, at least for a short period of time, where
Mhm.
they really clean it up and see, oh, wow, wait,
Mhm.
my belly doesn't hurt. I'm not bloated. I don't feel foggy. I can think at night.
Mhm.
These things are, they come very quickly. And, you and I see it every day with our patients. So I just want people to know that that's an option, and it is quick.
Mhm.
You make a huge change. It's dramatic.
It
You know.
is.
And I know.
I
So
know it is. No, I think it's so true. And again, kind of taking that power back, because I feel like again, and I feel like this pandemic is certainly sort of brought to light, I think, a lot of the things that we don't have control over.
mhm,
And I think that knowing that, look, I have control over what I eat, I have control over these choices that I'm making. Let me figure out what support I need, what structure, to kind of start making some changes,
right.
because that will ultimately, again, play a role in outcomes of not just COVID-19, but
Mhm.
of morbidity or mortality of chronic disease. I mean, we talk about, diabetes. It's the last time that I checked the statistics, it was estimated that a third of adults in the US are going to have diabetes by 2050. That's only 30 years away, a
Right.
third of us.
Yeah.
And diabetes is the leading cause of blindness, end stage renal disease requiring dialysis or transplant. I mean, amputations, lower extremity amputations. And so just thinking about, yes, for COVID-19, it's helpful. We have the data that it's helpful to be healthier at baseline, but also let's not forget the long-term morbidity and mortality.
Absolutely. Absolutely.
Yeah.
But the one other thing I really think we need to talk about today is testing.
Yes.
So, there's been a slow process to get testing
Mhm.
available for people who are sick,
Mhm.
for lots of reasons. And I think that there's a lot of political uproar, and I'm not going to get into any of that.
Mhm.
But I think there are certain patient populations that it is important to test to find out.
Mhm.
And it's not everybody, because, I think the most important thing we can do right now, we are flattening the curve. We have made a difference. People staying home and being safe.
Yes.
It's allowed us as a healthcare system to prepare for the most part. Some people got crushed early and there was no way around that. But the rest of us are in a position where my hospital built 80 new ICU beds, and
Wow.
we're
That's
using them.
remarkable.
But they weren't there 5 weeks ago, and they are there now. 80 ICU beds in a 450 bed hospital. So this is a completely different world.
Mhm.
That being said, I think everybody just has to pretend that they have the illness
Mhm.
and treat everybody else as if, ooh, I got it. I don't want to give it to you. And
Mhm.
the reason I say that is they just did this really interesting study up at a homeless shelter in Boston, and it
Oh,
made the
yes, I'm glad you brought that up. Mhm.
so they were concerned that there was COVID in the shelter, so they had tests, and they're like, we're going to test everybody and see what happens.
Mhm.
397 people in the homeless shelter, 146 people tested positive. Guess
Mhm.
how many of them had symptoms? Dear
Zero.
God, nobody had symptoms. And these are homeless people. These are people with comorbidities. These are people that
Mhm.
are, not in the best of health.
Mhm.
And none of them had symptoms, and almost half of them had positive PCR, the nasopharyngeal swab
Mhm.
testing, which means they have active infection now. So
Mhm.
they separated them, and we'll see what happens. But we kind of assume that everybody else in there was already
Right.
exposed. So
Mhm.
I don't know where that process will go. So if you're
Mhm.
sick, if you work in a healthcare facility, if you work in a facility and you're still going to work with a lot of other people and you start to have symptoms, you probably need to be tested. And there's local testing available for most areas now.
Mhm.
Um, some people are like, oh, God, I was so sick in January and I had all of this stuff and the cough lasted a month and I'm finally better. Can I go get this antibody test and find out,
Mhm.
did I have COVID? And you and I talked about this. We
Yes.
have to be a little cautious right now, because when even the nasopharyngeal swabs, when they first came out, many people in the medical field felt like there were about 30% false negatives, which means the
Mhm.
test was negative, but we were really sure that they had the
Got it.
disease.
Mhm.
The issue with the antibody test is we don't really know where the false negatives and positives are. So
Mhm.
even if the confidence interval is 90%, there's a 10% wiggle room there. Is it false positive? Is it false negative? If you get a positive test, you're like, okay, I already had it, I'm immune. What if that test isn't right? And we don't
Right.
have
What if
enough
it's
data to
mhm,
show us that the testing is accurate 100%. It's not 100%. So if you get a false positive test, which means I was sick, I got better, I should be immune, and
mhm.
you go out and act as if you're immune, how do we know that you really are? How do we know you're not going to get sick? So right now, my best advice, and I know you agree with me, is for
Mhm.
everybody just to act, I got it, I'm not giving it to anybody else, and we'll see how this antibody testing plays out. I think from an epidemiological perspective, there is going to be a role for it.
Mhm.
And you're seeing,
Absolutely.
I think they're doing a big study in New York with 5,000 patients currently, people that think they've recovered, and we're going to see where those numbers play out. But I think there are a lot of testing options that are becoming available through mainstream and other testing sites. And I just don't think the data's there yet. What do you think? Do you think?
Absolutely. Yeah. I mean, I agree with you. I think that there are a lot of tests available and there are different types of tests. Some are the finger stick tests that people can do at home and it comes up as a pregnancy test where it tells you whether you have the antibodies. Yes. And then some are the phlebotomy tests where you actually get the blood drawn from your vein, which tend to have greater accuracy. However, because and there's a lot of enthusiasm and I absolutely agree with you, Tricia. There's going to be a role for this. We're all going to want to know, did we have it and did we build immunity to it? Just like when we test people for MMR, measles, mumps, and rubella, or just like when we, you know what I mean? It's something that yes, it will be important to know. But do we know yet? And what are the official CDC guidelines? And what are the Department of Health guidelines? Certainly here in my state, I know that the guidelines are exercise caution. Don't recommend that your patients get tested with a test that has not yet been validated or approved by the FDA. Now, there is a caveat. I know that Mount Sinai here, if you're watching and if you are here in New York and if you may have recovered from COVID-19, I know that Mount Sinai has made a test available that you can find on their website that has been given the emergency use authorization from the FDA, where they're actually looking for people who may potentially be interested in being plasma donors, because of course that's another study and potential treatment option that's being investigated. So people who may have recovered from COVID-19, who have the antibodies, could they potentially um, provide their plasma and their antibodies to somebody who has an active infection to speed up their recovery, improve their chances of survival? That's a big research question. And certainly if I were in that position where I've had COVID-19, that would probably be my go-to. Go to an academic institution, see if you can help, if you can, but otherwise, I think it's premature. That's my sense, still, if we don't know if there's a potential to give people a false reassurance, that's really the biggest, concern to me. You think you may have had it, you get the positive test. Who knows? Did it cross-react with another coronavirus that you may have had years ago?
There's a
Um,
lot of
and
coronaviruses
then
out
you
there.
go
We
out there.
diagnose them all the time.
Right. Yeah. So I agree. I mean, I think exercise caution, monitor what the FDA and CDC are recommending and go by that.
Is there going to be a role for this? Yes, there's going to be a role for this. I think we're just not there yet. Like with a lot of things, we're just not there with this disease and we're learning as we go along. So the best thing, just keep yourself safe, act like you're sick, and continue to protect your fellow man. And that means a mask when you go out and, not touching your face and washing your hands and doing all of social distancing. Those things we're already doing. Keep doing them for now. And even as things open back up, which they are going to in some places, and then there are places with a very low incidence of disease, but we want everybody to stay that way. So if you continue to act like you're sick, even if you're going to the store or you're, in getting together with people, then you're not going to share it, even if you are sick, or you're one of those 146 homeless guys who have no symptoms and actively have the illness. That's the scary part to me. We don't know who is an asymptomatic carrier. You don't have to be sick to share with your friends.
I completely agree with you. I think you're so right. And it's, as we know, it's been an evolving story and a rapidly a rapidly evolving one as well. So I think that just being aware, we don't necessarily have to be, peeled to the TV.
Yeah, so from the news, a news fast is a really good idea. Stay aware of what's going on, but you can really go down the rabbit hole of following this and all of the drama involved, and there is way too much drama involved. And that increases our stress levels, and that increases our inflammation, and that makes us sicker. So,
Absolutely. I
yeah.
completely agree with you. Yes, stay informed, but not peel to the news. And really, I think that keeping the lifestyle and self-care conversation is really important during this time as well. But this was such a pleasure, Tricia. Thank you so much.
To talk with you. Thank you for having me on, and looking forward to sharing this with all of your patients and all of my patients. And we will just keep spreading the word. I mean, we're going to get through this. We're going to get through it
Yes,
together.
yes, absolutely. Thank you so much.
All right. Have a great day. Talk to you later.
Thank you. You too. Bye.